Thank you for the opportunity. I am going to talk on simple approach for the complex fistula. I am Dr. Samrat Jankar, bring greeting from Symbiosis University Hospital Research Center, Pune. So, when there is a complex fistula, we get overwhelmed because there is a leaf, there is a fish, there is a perfect tropice, waft, advancement flap, seton, Kshar Sutra, fibrin plug, stem cell, n number of procedure. So become so many procedure and one disease. It's become bit of complex even to treat a complex fistula. So it's kind of blind man with elephant. So everyone reaches blindly and to that area and they perceive that that is something what they see and that is the best one the thing is. So separate and single-minded study by the authority have led to widely despairing and even contradictory account that has been quoted in the American Surgeon General in 1987. So same thing has been applicable in our fistula also. For simplification, there is a American Colorectal Society has been developed the standard practice task force. They made a classification as a fistula as a simple and which is simple where we can do the sphincter cutting surgery with risk of incontinence is minimal, which is the best for the fistula. But if it goes to complex, what they tell is where we risk of incontinence is high. If we go for the sphincter cutting surgery, we have to prefer a sphincter preserving surgery. This was very simple, but the word complex has led to a lot of issue. Drawback of this system is, in fact, this has been published by Dr. Gerg, 32% of the complex fistula are amenable for simple fistulotomy. Just overestimation of the complexity led to go for the sphincter preserving surgery, and in fact it will be the consequence going for the recurrence and more other problem. And second thing, this is not useful to differentiate type of the different fistula patterns, complexity and specific management. So I am thankful for my mentor. I have been trained under Dr. Rajna Sukal and Dr. Parvez Sheikh sir. In fact, my further talk is little bit biased because I have been trained under them and the thought process I am presenting just to make a simple approach towards the fistula. So whenever I talk on the fistula, this is very important statement I personally believe. This is anatomy and pattern is constant. It's a surgeon, we have to learn it. Anogenital sepsis is predictable. There is nothing rocket science. It is highly predictable disease. We have to put our brain. It's always spread between the muscle and spaces until and unless surgeon has done iatrogenic fistula or there is a non-cryptoglandular disease. So to simplify, anatomy is constant. What anatomy? Actually, this is the anatomy what Dr. Rajna Sukal has been even published. This is the levator and even deep part of the external sphincter and levator and puborectalis. He will call it as an levator, and it has been seen on multiple cadaver what he has dissected more than hundreds of cadaver. Second part is superficial external sphincter, which is connecting to the coccyx by the anococcygeal ligament, separated anteriorly by the perineum by superficial transverse perineum. Third part is the subcutaneous part, which is corollary to the bulbocavernous anteriorly. So this is the three level concept of the simple striated muscle. What is its implication? The upper level, what we call as a levator level, don't divide. If you divide, it will not leave you, you will land in the incontinence. Second level, if we divide middle level, it will be a not problem until and unless there is a 3-4 condition: anterior female, post radiation, prior incontinence, or patient is having IBD. In fact, middle level you divide, take 1 or 2 PDS stitch, more than enough, patient will not land incontinence. Lower level, that is subcutaneous 8 mm to 1 centimeter, you divide, there is no question of incontinence because these are the simple treatable fistula in this area. So after seeing the muscle, there are 3 important fascia we need to learn. There is some intersphincteric fascia in between the 2 sphincter, some oblique fascia which has been not defined in the anatomy. Dr. Rajna Sukal has seen on the cadaver, and in fact he has many cadaveric images that is going obliquely, and he called lateral space as a not ischiorectal, ischioanal, and ischioanal space into upper one infralevator and ischioanal fossa, and there is a transversalis fascia. Going further, there is a anogenital spaces. Anogenital spaces are 3 set of anogenital spaces. Something is medial. Medial means medial to the external sphincter. Intersphincteric, that is low intersphincteric, high intersphincteric, supralevator. It's easy to drain because there is nothing need to be done outside. Just divide the internal sphincter. Internal sphincter, in fact, we divide till the anorectal junction. There may be possible in early phase patient may have a urge incontinence, but definitely patient is not going to have a incontinence per se. Only thing is, whenever we are doing MRI, we have to ask radiologist, is the hyperintensity is medial or lateral? If it is completely medial, it becomes simple to treat, and this is related with medial spaces. What is lateral spaces? Lateral spaces, it can be lowermost, below the transversalis fascia, that is perianal space, more painful, ischianal space and infralevator space. We have to ask radiologist, is the abscess is below the levator, above the levator, medial to the external sphincter, lateral to the external sphincter. If it is medial and above, it is supralevator or intrasphincteric, just inside the anal canal, drain, divide or get the disease out. Simply we can treat. If it goes lateral, perianal, usually it is a low transsphincteric, that's not at all question. Ischianal or infralevator, if there is an abscess, we have done MRI, ask the radiologist, is the abscess is below the levator? If it is below the levator, put your finger into the anal canal and drain it. If you don't drain infralevator abscess, post-operative patient will not going to get settled up because ischianal fossa plane has been not opened up. And these are the important spaces. We surgeon tend to ignore it. That is a deep post-anal space lies outside the external sphincter below the anococcygeal ligament. Deep perineum space lies anterior to the anteriorly between 1 o'clock to 11 o'clock. These also hidden spaces we should not leave, we have to drain it. So if we see this, upper one below the levator, above the levator is supra levator, below the levator, above the ischianal plane is infralevator space, and between the ischianal plane and transversalis plane, that is ischianal fossa space. Going below it is a perineum. Anteriorly that is a deep perineum and posteriorly that is a deep postanal. In between the sphincter, intersphincteric, almost 7 spaces. And one thing Dr. Garg has quoted is Raphael space. What he call is just it is a sublevator space, which is also posterior high transsphincteric fistula. These are the simple spaces. Ask the radiologist on MRI and try to drain it. Leaving that undrained collection laterally is also cause of recurrence. Going ahead, pathogenesis of anogenital sepsis, I have already discussed. The disease start at the dentate as a cryptoglandular, something which goes in between the sphincter, which get the internal sphincter spasm. It has to travel down as a low intersphincteric, high intersphincteric, low transsphincteric or high transsphincteric. Our only concern is high transsphincteric, not other fistula will going to cause any kind of incontinence. So based on that, he has divided into a 5 pattern, that is a low intersphincteric fistula, high intersphincteric fistula, low intersphincteric, low transsphincteric. Anteriorly and posteriorly, a high transsphincteric deal with a different spaces. Because of that, he has labeled anterior high, which is going through a deep perineum space, posterior high, which is going to deep postanal space, something which goes high intersphincteric, supralevator, abdominal, which will become the high intersphincteric. Only 5 pattern. This pattern and this anatomy we know, most of the part is solved in fistula treatment. Going ahead, what are the essential component of the fistula? The essential component is internal sphincter and intersphincteric space, internal opening, intersphincteric space, intersphincteric area where the whole thing has been evolved, or this is the area battleground. And going to a transsphincteric, our concern is only the external sphincter, whether to divide or not to divide. Wherever possible, divide it, which will going to give a best outcome, because we don't want to have a recurrence. But at the same time, if it is high transsphincteric dividing, patient have a risk of incontinence, we have to tailor our procedure. Going a last component, distal component, wherever spaces it goes, we have to drain, either simple curate, excise, laser, everything work distally if you tackle these 3 components. Internal opening is the most important. The surgeon has to do PR, identify the internal opening, either in induration or some amount of pit we can see. The pus is coming from internal opening, we can identify. There is a puckering at the internal opening, that also help in identification. Hydrogen peroxide, usually in abscess patient, I usually tend to avoid because itself it will increase the induration. Gentle probing should be done cautiously, and best is MRI. If we club, it's not one thing which will give internal opening. We have to see all these things, and most important is per rectal examination, which will find out the internal opening. Going ahead, if we have the finding anatomy, pathology, then what is the ideal treatment for fistula? Something which will completely eradicate sepsis, something which will promote the early healing, preserve the external sphincter and maintain the continence. The continence should be maintained and disease has to be out. That's the thought process behind the fistula treatment. In any fistula, I want to balance between the recurrence and continence. So to become over-enthusiastic surgeon to avoid the recurrence, I should not land patient in incontinence. Per se, if it is a complex fistula, I will wait for the continence because someone else is there, he can do the best for the patient. I will tell the patient, in my hand recurrence is possible, but I will not allow any continence to go off. That is a safety we have to measure. So based on that thought process, we can divide the fistula surgery into three types. Something which is best, which has been told, is a sphincter cutting procedure, which is applicable for all the low fistula where incontinence is not risk, which can be fistulotomy, fistulectomy, Saurashtra and cutting set-on. In every case, intersphincteric area and proximal intersphincteric tract has to be tackled. Something sphincter preserving, which we tell everything, whatever we talk is stropis, waft, lip, fibrin glue, fibrin plug, pill take, advancement plug, everything come in the sphincter preserving procedure. Mind it, when we are applying this procedure, recurrence is inevitable and incontinence is less likely, and these are the safe procedure. Everyone should choose something of which is suitable and which is best in our hand. And last one is sphincter function preserving procedure. What actually fistulectomy, immediate sphincter repair we do, sphincter function preserving procedure. It is a sphincter cutting, but we repair and preserve the function. So this procedure has a best outcome, but incontinence is a risk. If there is a no incontinence risk, this is the procedure. If there is a risk of incontinence, then this is a procedure, but we cannot go for this. This is expert we can do, but most of us, we have to stick in sphincter preserving procedure. So focus on sphincter preserving, because everywhere we go, there is a many procedure has been taught is a sphincter preserving. There are only three thought process goes in sphincter preserving. Something which tackle the internal opening, like a advancement flap, slop, tropis, goes on hit on internal opening and internal sphincter. Something which track on intersphincteric space, lift, modified lip, biolip, these are tacking on the intersphincteric space, leaving the submucosal area, glandular area, risk of recurrence is high. Something which track, focus on everything, that those are the thing, waft, filac, fibrin glue, fibrin plug, stem cell, focus on every part. But the problem is, these are the sphincter preserving procedure. Incontinence is less likely if done well, but recurrence is more likely. We have to explain to the patient. The pill take, what I do as a modified lift, which I had to add into sphincter preserving. It is not the best procedure, but it is one of the sphincter preserving. Pill take, what I label as a proximal intersphincteric fistulectomy, followed by ligation of the tract over the external sphincter and curating and excision of the distal tract. So what pathogenesis happen in anogenital sepsis? Stool comes which goes into the tract, infect and persistently discharge. Whenever there is a high tract, then only sphincter preserving procedure come in existence, otherwise sphincter cutting is the best. I do all the procedure in the prone because this give more advantage for me identifying the pathology, and also make a comfort. Doing lithotomy is not at all problem. So I go in intersphincteric space as described by Rajna Sukal sir, and after going intersphincteric space, then I modify my procedure as excision of this block, which is nothing but as already published in the literature as a modified procedure. We have to excise the central disease. We just should not leave this. Excise with a 5 mm margin, and then in lift, what has been quoted is doing the ligation on the both the side. In pill take, what I do is excision of the central disease first, and then I ligate over the external sphincter. So after that, intersphincteric area, there is a deep intersphincteric area which is also culprit left over glandular tissue. I cauterize with a bipolar. Then followed by ligation of the tract over the external sphincter, so that we can disconnect from the anal canal, which will help. And curate, laser ablate or excision of the distal tract. So what I feel my approach for any kind of fistula, this is my just thought process. This cannot be a evidence based or anything. This is every case central disease is culprit. We have to accept that we don't want recurrence without having incontinence. Excise central disease I call as a proximal intersphincteric fistulectomy. If it is simple, go for complete sphincter cutting procedure. If it is complex, choose between two. Is it sphincter preserving? Whatever you do, pill take, lift, waft, whatever best, choose the sphincter preserving procedure, or go for the sphincter function preserving if we are expert. What my routine thought process is, at least 2 attempts of sphincter preserving procedure I give. If not working, patient is frustrated and he want to get rid of the fistula, then only I go for the sphincter function preserving procedure. That is nothing but fistulectomy with primary sphincter repair. If disease, then abscess, another one challenge which I had. There is a perianal abscess and complex fistula. We keep it as a separate as a surgeon, as acute and chronic manifestation. Dr. Rajna Sukal quote this as anogenital sepsis. So make it simple, every anal condition, perianal condition related with a fistula, let it be sinus, let it be abscess, let it be fistula, tell as anogenital sepsis, your mind will work what is a pattern, how to deal the disease. So going ahead, if it is anogenital sepsis, it can be intrasphincteric, it can be low transsphincteric, it can be high transsphincteric. So in these two patients, why to do just IND? Just take out complete disease so that patient will have good outcome. Only 20% of high transsphincteric fistula which has been noted on MRI, those only need a sphincter preserving procedure. You do IND or set on. So what logically I think is, if it is a simple anogenital sepsis or complex anogenital sepsis, simple means intrasphincteric, let it be high, low, just divide everything, patient will get a good outcome. And that synchronous treatment, fistulotomy with IND will be better. If it goes high transsphincteric or low transsphincteric, anterior low transsphincteric, in those conditions, we can think about IND with set-on, which is a safe. If at all you are expert, you can think about synchronous treatment, whatever feel best in our hand. This is what the thought process of mind. So to conclude, the fistula, if feasible, do MRI in every case. Don't tell that it is costly, because it is less costly than laser and your recurrence. And going ahead, you should start calling anogenital sepsis. Mind will not think that it is abscess, I do differently, it is fistula, I do differently. Mind will tell that if they see the pattern, what we can do for the patient. And go always document the pattern and map before the surgery. You can plan before going into a table. Then tailor your procedure based on complexity and expertise. No procedure is perfect in fistula except the sphincter cutting. Tailor your procedure, what expertise you are having in the treatment, and what is the complexity of the patient by assessing MRI and physical finding. And adopt the prone position. I feel it is the best one. If it is possible, adopt the prone. It will make ergonomically more better. And also what is, I feel hindrance is, it takes the time. If I want to do lithotomy, 2 minutes assistant will do. In prone position, it takes the time. In fact, spending 5 minutes before the surgery, mind will also give up more and more better planning. And internal opening, always better appreciated in prone position. And you can excise the central disease first rather than dealing laterally. Excise central disease, so you have done 50-60% of recurrence-free disease. So I feel that first surgeon is the best surgeon. Do your best, always prioritize safety, don't land in incontinence. Even if there is a recurrence, it can be managed at a second attempt. Tell the patient that I will do a second attempt also. Or even someone else who can do the better, refer to them, they can do better. Many of the people in every corner, they are doing best fistula surgery. Thank you.
Thank you, Dr. Samrat. Really, he made the fistula so simple that I think many of the persons who are not doing fistula in audience might start doing it from tomorrow. So simplified, very well explained, the species and the way you have to handle the fistula, how to classify between a simple and complex, very well. Thank you, Samrat.
Thank you, sir. Thanks a lot, sir.